Hello and thank you. It is great to be partners with all of you on this patient safety movement. Our project is at CHOC Children's Hospital in Orange County, the real estate in which you are right now. Our hospital briefly is a 278-bed children's hospital, freestanding, not-for-profit, academically affiliated, and our mission is to nurture, advance, and protect the health and well-being of children. We have the responsibility, the privilege, we daily aspire to deliver health care to some 2 million children in Orange County and its surrounding areas. It is indeed a challenge. Our commitment and long-standing effort, really since the mid-2000s, is around the idea of preventing patient deterioration. This is really about non-ICU patients. This is about patients who have become sicker over the years. Last decades, 2 decades ago, these patients would have been in ICUs, now they're on wards. And our energies have been to move away from the conventional wisdom that codes were, in effect, the cost of doing business. Resuscitations occurred rather randomly. You knew they were going to happen, you couldn't tell who it was going to happen to. Wonderful research in the adult world in the mid-90s and subsequent to that demonstrated that, in fact, there were warning signs in these patients who were deteriorating. There was evidence for even several to many hours ahead of time that things were about to erupt in a negative sort of way. The pediatric community, of which we are one small piece, agreed with this, looked at it closely and said, let's look and try and get ahead of the curve. Let's, well before the final code event, move backward in time, further along this deterioration continuum, and intervene while it's still possible to make a difference. At our facility, we looked at 3 different time points. One was the rather traditional rapid response team or medical emergency team, which was called in very standardized fashion by anybody in the hospital. Yes, there were reasons that we suggested you do this, but the culture change was really to say anyone can do this. And importantly, in our world, that included families. Then we moved backward in time further and looked at what we call an early assessment rounding team, in which at the beginning of the evening shift, we would identify those 1 or 2 patients in a given ward that everybody knows who they are, they're the ones you're worrying about. And the nurses and the residents would get together and they'd proactively meet those patients and their families. And they'd say, what can we do and what's going on? And that was very effective, but it was limited in its scope because we couldn't look at all the patients at the same time. So we borrowed shamelessly from others and refined what we called pediatric early warning system, a PEWS score, and it really is a standardized score based on traditional nursing assessments done every 4 hours at a maximum for patients who are in non-ICU status. And it looks at just simple physiological things that we do all the time: cardiac, respiratory, neurological. And those are scored. And if the score is not what we want it to be, if the patient looks like they are getting worse, then we look more closely and we look more often. And we have mandated response algorithms, both communication with providers or bedside visits within brief numbers of minutes, 5 minutes, those kinds of times. If these sounds like checklists, that's exactly what they are. I sort of went over the elements already. They were effective in their own ways, and we did them all over the course of a couple of years. Our results were significant. When we looked at our pre-baseline, pre-RRT and EAR and PEWS results, we decreased our non-ICU code rate over 2 years by 87%. Translate that, it's about 45 to 50 avoided codes a year. Importantly, we sustained that for the last 5 years. We think that we really captured almost all the preventable codes that occur in the children's hospital environment and are pleased where we are. We would like to get that, of course, all the way down. In closing, I would like to say that this gratifying change is meant to upset the traditional wisdom that you cannot get to zero. We were very skeptical that we could do these sorts of things. Our many partners in pediatric healthcare would say the same thing, and yet we're closer than ever to getting to the true reduction and prevention of healthcare acquired deterioration. Thank you very much.